We have Amy. She is a specialty area manager at Inhabit Home Health and Hospice in Georgetown, Texas. And then we have Stacy, who was born and raised in Austin. She graduated from the University of Texas at Austin with a BBA in marketing. Stacy is the director of operations at Visiting Angels Georgetown and represents the organization in the community by visiting with families, business, and medical professionals to make sure Visiting Angels does their best to keep folks in the house. So now I've told you about them, but I want to get a little bit more specific. So basically, Stacy is with a home care company and Amy is with a home health company. So I'd like you to both elaborate a little bit on that. I'll have Amy go first just because I'm going to go alphabetically to start. But I just really want you guys to tell us, like, what do you do and how distinguish between the two of the services?
Sure. Hi, y'all. My name is Amy. I'm a physical therapist assistant, and I work for Inhabit Home Health, as she said. The biggest difference with home health is we are skilled services that come into your home to help with your medical needs. And by skilled services, I mean physical therapy, occupational therapy, speech therapy, nursing, and we also offer medical social workers as well. So with those services, we come and do an evaluation, see how you're doing based off the orders from your doctor. And with that, we will create a care plan for you, discuss it with you, discuss it with the doctor, get it signed off on, and then we create that program and implement it with you in the home to work on just getting your maximum independence so that you can live, a fulfilled life.
And what about you, Stacy?
Hi, I'm Stacy with Visiting Angels Home Care. So home care, the difference would be we provide caregivers that can be hired typically on a per hour basis to help with activities of daily living. These caregivers can provide that care either in the home setting or wherever somebody is living at the time. So we do go into hospitals or assisted living communities, memory care communities too. We provide things from personal care assistance, transportation assistance, and homemaker services. So things there around the home. So we are the non-skilled or non-medical care in the home.
I want to get a little bit more specific because having worked in the field, I know what is covered and what is not by some of these definitions. So I do kind of want to get a little bit more into it. For example, you mentioned transportation, but when you say that, that usually does not mean transportation for a person to the doctor's office. Am I correct? Or could you tell me a little bit more about that?
So it is going to vary, state by state, possibly even city by city. So here in Texas, home care does include like one-on-one transportation to and from doctor's appointments, running errands. The caregiver can drive their own personal vehicle, run an errand for a client, pick up groceries and come back to their house. Or we actually do drive clients either in the caregiver's vehicle or the client's vehicle to and from places. But that is here in Texas, and it can be different state to state.
Something people want to look in, because I know in the state of Florida, they can do errands without you in the vehicle. They cannot take you in the vehicle for insurance.
Yeah, here in Texas, you can.
And then when you talk about some of the non-skilled, that's help with bathing, for example, if people needed help daily, for example.
Yeah, so typically it's on an hourly basis. Agencies are going to operate differently, their requirements on scheduling, whether they have any minimums that they require, like 12 hours a week or 4-hour shifts. So you do want to research that if you're looking into different options and ask them what their scheduling requirements are. But you're typically scheduling it the times that you want, the frequency you want, the days that you want, and you can change those schedules based on your needs. And you decide what tasks you want the caregiver to help with as well. So like you mentioned, the bathing, it's going to be your activities of daily living, like showering, dressing, toileting, help with mobility and transfers if you do need assistance getting in and out of bed or into the wheelchair, incontinence care, medication reminders, and then the things there around the home, like making meals, laundry, doing dishes, changing bed linens, taking the trash out. And they are companions if someone needs, just wants to play games or do puzzles or do some gardening or go walk the dog together, that's included too.
Amy, can you tell me a little bit more about the skilled services and also how one gets them? Because you can't just say, hey, I'd like some skilled nursing. I mean, it would be wonderful, but it doesn't work like that.
Yeah, correct. So our patients who come to home health, they come based off of a doctor's referral. It could also come from a hospital referral, an assisted living referral as well. So if you're in the hospital for several days and the doctors who are taking care of you there say, hey, we're going to send you home, but we think you need a little extra help at home, we're going to provide home health. That would be considered an order from the hospital. If you have a specialist that you're seeing or your PCP, if you're going in for a neurology appointment, and your neurologist says, hey, we've noticed a lot of falls recently, let's get some help at home to work on your strengthening and balance, that referral would come from your doctor's office. And then if you live in a facility and they're just noticing that you're having some problems there, the facility themselves can order it as well with the doctors who work in the facility. So with those orders, the doctor will specify what needs. So when you go in for your doctor's visit, you can say, hey, I'm having trouble remembering when to take my medications, how much I'm supposed to be taking. I'm getting them very confused, and then I'm not getting the benefits from them because I'm not taking them appropriately. Or you can say, I've been having a lot of falls. My balance has really just gone downhill. Hey, my speech is getting a little worse, a little more slurred. I'm having trouble swallowing. And then the doctor will say, okay, this is what I think you need based on whatever it is you're telling them that you're having issues with at home. And so that doctor will send the order. So if it is a strengthening or balance issue, they usually will refer you for physical therapy, who will work on that in the home. If there is medication management or insulin issues or anything else like that, they will recommend a nurse and order a nurse for you who will come out and help you with those things. If you are having issues with some of the activities of daily living, like getting into a shower safely and out and being able to dry yourself without losing your balance, if you're having trouble getting dressed on an everyday occasion, if you can't stand at a kitchen sink long enough to do the dishes, that type of thing, we would probably recommend an occupational therapist, or the doctor would send over a referral for an occupational therapist to work on those things with you. And then if you're having some cognitive issues with memory and forgetting things, or having trouble swallowing or having clear speech, then they would probably recommend a speech therapist who works on not only just pronunciation, the tone, your throat muscles, but also with the cognitive components as well. And then we do provide a medical social worker. So if you're in a stage of your life where you're like, hey, I'm living at home, things are getting a little dangerous, I know I need some help, but I also need to think about what's going to happen in the next couple of years for my safety, a medical social worker can walk you through what next steps are, what kind of services are available to you. If it's time to start looking into a facility to move into, an assisted living or an independent living, anything like that, where you just have a little bit more support. The social worker can go through that with you and make a game plan with you, which is really nice too, while still giving you your independence in the home. So everything does come from a doctor, whether it's a doctor in a facility, in a hospital, or from your doctor's office, but they will send it to their home health. And then we work on getting you started. We do come out with an initial evaluation. So if they ordered physical therapy and speech therapy because you're having balance issues and some cognitive issues, then we would send one of those clinicians out first to do an evaluation on you. So We go through all of your history, all the things that have been going on, a lot of questions. It's a little bit longer than just a normal visit because we're getting your whole background. But then based off that evaluation that's when we decide your plan of care, how frequently we'll come out to see you, how many times a week, what we're going to focus on those visits. We let your doctor know. The doctor has to approve those visits. Most agencies are going to send somebody out 2 to 3 times a week, depending on what you need and depending on how many services your doctor has ordered for you. So if they ordered 3 different services, physical therapy, speech therapy, and occupational therapy, that's a lot of visits in a week. Some patients might not want to be seen twice a week by every single discipline because they're like, hey, I'm too tired. Like that's 6 visits in 7 days, you know? So we discuss that with you. We discuss it with the doctor, and that's how we make up a care plan for you guys.
And then how do people come to you versus doing an outpatient? Can we talk a little bit about, usually it's considered homebound status. What does that look like?
Yes, so one of the biggest things to qualify for a home health agency is you have to be considered homebound, and that's a Medicare guideline that we follow. Every good agency will follow that as well. So some of the things that are really big to be considered homebound, like the easiest definition is to think of it's a taxing effort to do anything, to leave your home, to get dressed in the morning, to get in the car. It's a taxing effort to do any of that. But some other like more specific indicators or do you have a risk of falling and injuring yourself? Are you using a new assisted device? Are you recently on a cane or on a walker? Do you need one of those and you haven't been able to get one of them? Have you noticed that you have like significant shortness of breath anytime you do anything in your home? Or that you feel super weak and you have to take a really long break after you complete an activity. Those are all very good indicators just for yourself that you are homebound. There's also, if you have a huge fear or anxiety of leaving your home because you know you get tired, you don't want to have to take breaks in front of people or anything like that. That's also, that fear and anxiety can also lead you to being homebound. But then your doctors are also going to be looking at indicators for your homebound as well. So that's just if you have a chronic or an acute pain that's impairing your function of daily living. If you have any medication changes that they've sent to you and they're trying to get your medications figured out. If they know that you have a risk of injuring yourself for a fall or you've had a recent hospitalization, or any infections or injuries that they want a little extra eye on, that could be a good one. If they think that maybe there's some knowledge deficits with you, whether it's about a new diagnosis or a new medication or anything like that, nutrition, signs and symptoms to look out for with your diagnosis, they can say, hey, we need somebody in the home to help kind of just guide us along. But also if they notice that your activity tolerance has gone down, vision, strength, balance, any type of edema, swallowing, impairments in breathing, all of those things would mark you for a homebound status for a clinician, for a doctor to look at you and say, hey, let's refer them to home health. Now, with that being said, our goal is always to get you strong enough to either go to an outpatient clinic if you still need continued therapy, or just to be independent on your own. But you cannot do outpatient therapy and home health at the same time. Medicare does not allow for us to coincide. You also can't be getting one discipline. So you can't be getting nursing from one home health agency and then have another doctor order physical therapy at a different home health agency. You can only have one home health agency at a time. And the reasonings for those, if you're going to an outpatient setting, then Medicare is saying, hey, this patient's getting to somewhere 2 to 3 times a week on their own. They don't need services to come to their home because they're going out. So they're not homebound. And then as far as just having 2 different agencies, that's just considered a duplication of services. If you're getting a service from one, you should be able to get multiple services from one agency.
Thank you.
That answered the question.
That was awesome. Yes. But now it makes Stacy. So we see how people come to Amy, you know, via home health, via referral from their doctor. What happens when someone's kind of like, I think I could use some help? They call you. What then is the process? What, first of all, what should they be looking for to kind of say, I need help? But then what happens when they reach out to you? Is there an intake? Can you tell me a little bit about that?
Yes. So some identifiers that we typically see are something has happened recently, right? Whether we've had a recent fall or a few falls, I've had a procedure or a surgery, or I've just noticed a general things feel harder. I'm more tired. It's more taxing when I think about trying to do everything I need to do in my normal daily routine. You know, I just can't get to it all, or it seems unsafe for me to do some of these things on my own. So you're noticing a sense of fear and wanting to get some type of support. And some people do have, you know, friends and family that can step in and help with some of that. But at some point, you notice even that is too much. And gosh, wouldn't it be nice if I could just schedule someone to be here when I want them at the times that I need them and not have to always rely on outside, you know, family and friend resources, or I may not have anybody local that I can lean on to do those types of things. So once someone does identify, I think I need a caregiver or someone to come, you know, to my house and help me, they call us. We will find out a little bit about what's going on, you know, answer their questions. If from there it does sound like it's something they're interested in, we offer a free in-home assessment. That is pretty typical of a lot of home care agencies, where they will come out, meet with you in the home for free, and ultimately answer your questions, offer suggestions on how we can help and what that might look like. Of course, go over pricing options and ultimately creating a care plan together that is decided upon by the client themselves. So that's what's nice about home care, is because there is no doctor's order. It doesn't go through Medicare, you know, insurance. You're the boss as the client. You tell us what you want help with and how often you want that help.
Have a good question though about what if a person rejects the idea of having help, even though they clearly need some assistance?
We do come across resistance a lot. You know, it is pretty common because it is overwhelming. It's a brand new concept. It's hard to, you know, to admit when we need help and we don't know how to ask for it. But it is a very gentle approach. You know, the hope is there's somebody else involved, you know, with that person who needs help that can help with those discussions. You know, we help with those discussions and come and meet with them in person without any obligation to ever sign up for anything, right? It's just a way for them to ask questions and hopefully realize maybe this could be helpful, and let's just try it, right? Many agencies are not going to require a contract and for you just to be stuck with it, right? We want you to try it. It may not be the right solution, but having the opportunity to just meet a caregiver, see how it goes, and see if it's helpful.
This is going to be for both of you, but I was going to ask this question later. It's about paying. Somebody asked, does your home care agency work with long-term healthcare, long-term policy insurance? So I was going to ask, like, how do you get paid through home care? And then Amy, same question with home health.
Yes, so for home care, we do take long-term care insurance. Many agencies will. You just want to ask, of course, specifically the one that you're interviewing with, if they do take long-term care. But typically, yes, Visiting Angels does. We also have the VA contract. So there are home cares that will have that contract with the VA to get services paid for qualifying veterans. And then otherwise it is out of pocket and you pay by the hour, whatever that hourly rate is for that specific agency. Every entity, every market is very different. They're all going to set their own pricing.
Yeah, and for home health, if you have Medicare, traditional Medicare as your primary insurance, you are covered at 100%. Home health was made by Medicare, so for Medicare age patients specifically. So that's why it's covered. We have seen tons of Advantage plans coming across over the last year. So we know Advantage plans are becoming more and more popular. My company specifically with Inhabit Home Health, we are working on making more and more contracts with those managed plans so that we can continue to reach more people. But it does vary state to state. Every agency is different on who they take and who they don't take. Here in Texas, there are 5 or 6 Inhabit branches within Central Texas, and we all take different insurances at each of those branches. So that would depend, but your home health agency that you're choosing should always tell you if there is going to be any type of out-of-pocket for you, whether it's a deductible or a copay or anything like that, or if you get a certain amount of visits. Especially with Inhabit, we make sure that we do not see any patient that's going to have an additional cost unless they tell us that it's okay, because we don't like to leave patients with a bill for these services. So if we can't see you free of cost and you do not have the ability to pay whatever the copay or deductible is, we do try to find an agency that you are in network with, so that way you can get the most benefits.
One remark tonight, I do just want to clarify, Medicare does not cover long-term care except for a short period after hospitalization. I just want to clarify, usually when people talk about long-term care, they do mean what Stacy does, which is more of a home care and not a home health.
Yeah.
Medicare does not cover any of those services. They will cover skilled, like what Amy does with the skilled nursing, PT, OT, speech, and social work. Stacy is more on the caregiving side, which is often considered long-term care, but that is more general housekeeping, personal care, bathing, companion services, for example, maybe running the errands or sitting and playing cards and being a companion. Medicare does not cover any of that. So I do just want to kind of clarify that, which kind of brings me to my next question for both of you. For Stacy, it would be, what is home care and what is it not? For Amy, it would be, what is home health and what is it not? Whoever would like to go first.
You got it, Stacy.
Okay. So I'd say the most common questions that I get with what is home care versus what it's not is that we are not a medical agency. You will see some, home health agencies like Amy works for. Some may have a non-medical or home care, caregiver service branch. So they may have both services to offer. Visiting Angels is strictly non-medical. So at least when we're talking about the category of home care, we are non-medical caregivers. So even though that caregiver coming into your home, she may be a CNA, a certified nursing assistant. She could be even a nurse, a retired nurse, nursing student, but there are always going to be parameters and a scope around what they can or can't do for medical services. So I know for us, and most commonly, that would be around like medication management and medication reminders. We cannot dose medication or fill the pill box for you. That would need to go through a licensed medical technician. So we also cannot provide wound care. That again would go through a medical agency similar to a home health agency. So even if that caregiver has the knowledge and they know how to do it, under a non-medical home care agency license, they cannot perform those medical tasks.
We also did talk about, hold on, that you don't cut nails. Like, yes, there's bathing, but
Yep.
that would be grooming. And
yes, we can do hygiene and grooming, but we cannot cut nails. We can help with shaving, but it has to be an electric razor and not, the other kind. We do provide light housekeeping, but we are not a professional cleaning service. We have a lot of people ask, well, should I just go ahead and cancel my monthly, cleaning service? But we recommend keeping that because caregivers are not going to do your heavy duty, deep cleaning items. It's more of your general upkeep and tidying up, dishes, maybe running the vacuum in a couple of spaces, making the bed and taking the trash out, some of your light duty things.
Yeah, so we're complete opposite. We do not come in for any type of daily task. We are there specifically on a plan of care that your doctor signs for each discipline. So if a nurse says they're going to see you twice a week for medication management, they're going to see you twice a week for medication management. And that's it. But with that being said, a nurse can fill your pill box for you. They can talk to you about medications. We can call your doctor and say, hey, she has this medication from you and this medication from another doctor, and they conflict with each other. So we can catch things like that and get those sorted out for you as well. We do not also provide any equipment. So if you do need a walker or a cane, or if you need a lift in your home, if you're the caregiver and the patient has just become too hard to transfer from a bed to a chair and you want a lift device, we don't provide those either. We can talk to your, again, doctor and say, hey, we need orders for these devices. We can supply you with resources to get those devices, where you can order a cane or a walker. We can measure those for you once they're in your home, make sure you're using them correctly, but we don't supply them ourselves. We don't keep any medical equipment within the home health agencies at all. So that's a big one. And then we can't also just come out for one visit. So a lot of times patients will be like, well, just come out, let's just see, just come out, and then I probably won't use you again. That's unfortunately not how it works. Once we go out, if you are homebound and need our services, it's a continued thing. Now, obviously, if we go out and you're like, I got to go pick up the grandkids, then I got to go meet my friends for bingo, then I'm having dinner after that, you're not homebound and you don't need our services. And then we can tell your doctor, hey, patient's actually very mobile. Let's send them to an outpatient group specific for their needs. So those, I think, are the big ones. Everything that we do will be skilled. And an easy way to think about it is, say you have a bad cut on your leg and it needs dressing changes. If the doctor says, hey, you can slap some Neosporin on it and put a Band-Aid over it and that should take care of it, that is not a skill. Anybody can apply Neosporin and a Band-Aid. If the doctor says you need a foam dressing, an antifungal, an anti-whatever, those are skilled services, because not everybody has access to those. Those are actual medications, so you don't have access to them. Not everybody can access foam dressings or ACE bandages or wraps. Those are all a skilled application that would go on to it. So if it's something that anyone could do, it is not considered a skill. But if it's something very specific, it would be considered a skill, and that is what we do.
Prior to us getting on, you also did give the example of an occupational therapist. So I just want to go over that one again for everyone.
Yes, of course. So if you need help bathing, we have occupational therapists who work on those daily activities like home care does as well. But we're going to focus more on the big picture of it and how to make you safe and comfortable with doing it. So if you're having trouble getting in and out of a shower or a bathtub because you can't lift your leg over the seal or there's no seat, we're going to show you how to safely get in. We might recommend you get some grab bars. We might recommend a shower seat so you can sit while you shower. We might look at getting a long-handled shower thing. What are those called? So that you can shower head. Thank you. So you can pull it towards you versus having to stand up and be close to it. So we're going to show you how to modify your environment for you to be safe. We will not come in to give you a shower every other day. We might do it one time to say, hey, let's try to reach this way. Or if you want to lean down while holding on here to get to your toes. Those are things that we could assist with the one time, but it's definitely more of an education thing than an actionable completion of a task for you.
I appreciate that because I just feel like you really explained it.
Yes.
We do have a question. Is there a time limit on the Medicare coverage for home health?
There's not. As long as there is evidence that a patient still requires home health, still is homebound, and is still benefiting from services, Medicare will continue to cover. So that's where you want to make sure you're getting a good home health agency who is doing their documentation appropriately, who has clinicians who are well-trained in home health, who understand the homebound status. So yeah, as long as we are showing all of that, we can keep a patient on. That being said, we are not here to keep them on forever. We don't want you on forever, and y'all don't want to be on forever. If you are needing continuous help for super long periods of time, we're going to recommend whatever the next service is, whether you need to go to an inpatient rehab for a little bit to get a little bit stronger to come back home, or if it's time to start looking into a facility like an assisted living where we can still see you, but you're getting a little bit more help as well.
Now, I do feel like one thing that can be a little confusing when people are looking is, how do they differentiate between the home care and home health? Are there buzzwords they should be looking for when they reach out? Is there something you would say? And then also, is there a place where there's recommendations? Because sometimes it's like if someone says, oh, I used Visiting Angels and it was wonderful, or I used Inhabit and it was wonderful, that's always great. But sometimes that doesn't happen. Is there something people should be looking for to kind of say this connotates that it's good, or is there anything like that? But also, what are the buzzwords they need to look for so that they know this is home care and this is home health? This is
so
for both of you.
for home care, it can be called many different things, like personal assistant services, non-medical care, home care, caregiver service, private duty care. And all of those mean the same thing. So it can get confusing, right? There's even medical professionals that call us home health when we're not home health. So you'll even see people in the industry get the two confused and kind of put us under that same umbrella. Even though we are not home health, they may just call it that as a generalized term. I do want to say, many people that we see are going to have both of us, because as you can tell, we're kind of two sides of the coin and we go really well together. We coordinate care often. We're seeing the same patients. When I'm in the home, I identify if someone needs home health, and when home health is in the home, they can easily identify when someone needs something more than what they can provide. They really are like a puzzle piece that fits together. Because we each do kind of the opposite. So many people need both. So definitely don't think of it as an either or. Very often you're going to have both at the same time for a period of time. And then how do you find a home care? How do you know if they have a good reputation? Ask around, number one, friends, family, word of mouth. That can be your biggest trigger to know who is truly doing a good job in your area. You can, if you are recently discharging home from somewhere, a hospital stay, a rehab hospital stay, their social workers and discharge planners will recommend who does a good job in that area. I think be careful of reviews you read, or word of mouth, rumors, and people like to spread things that just simply aren't true. That really seeking out the facts and asking people you trust if they've had a recent experience, how it went, and knowing what questions to ask. So always ask around, call more than just one, and compare which one works well for you, which has the right price range for you, who responded quickly, right? Who answered your questions, who can see you quickly and offers that free in-home assessment and will come and talk with you in person, and then knowing the right questions to then ask. And you'll get that sense and that feeling that they're the right group for you. So always look at multiples and compare.
You're saying I should listen to my sister then, instead of my sister's cousin's best friend's hairdresser's husband. Okay.
Exactly.
For us, it's very similar. Talk to people in your community who you trust, who are using home health, that they're likely to tell you who has been great for them, who hasn't. The other great thing is we work with doctors all day, every day. So your doctor will likely have a preferred provider that they like and they trust, and that they would like their patients to see. So like I know here in Georgetown, I work specifically with a couple of the neurologists, and we see the majority of their patients, just because I provide them with outcomes, and it's a trusted relationship. So your doctors in your area are likely to have that with the home health agency as well. The other thing you can do to look for any like good agencies in your area is cms.gov. That is Medicare's website that does all the ratings of home health agencies. So you can look at the ones in your area, you can see what their star ratings are. And that's a very unbiased opinion to go off of to look for someone that you need. But it's also the same too, if you're coming out of any type of facility, a hospital or rehab, or even if you had a short-term stay at a skilled nursing facility, those case managers and social workers should be able to provide you with a list of agencies in your area, and even more curated to you with what insurances they accept based off of your insurance. So it's a little easier if you're coming out of one of the facilities. But yeah, the cms.gov is probably the best way to look for in your area, or go with your trusted doctor's preference.
I know that y'all probably do not have specific Parkinson's training, but is that something that you guys kind of go over or try and do so that this way your staff is a little bit more familiar with Parkinson's? Oh, yeah. Okay, Amy's
So we actually have a whole entire, can y'all see this? It's a Parkinson's like layout program that we do specifically with Inhabit Home Health. Other agencies may or may not do it. But we do try to employ people who are clinicians who are big and loud certified, because that's a huge benefit to our Parkinson's patients, and because we see such a huge number of them in this area specifically, it's such a great benefit for them to have someone who is knowledgeable about big and loud. There's another program too for the speech side of it that's called something else, that we also have clinicians who are certified in that one as well. Still geared towards Parkinson's, just not called loud, similar concept. But yeah, so we do try to keep employees at least one or two of each discipline who are certified in those skills, specifically for our Parkinson's population.
Us as well, we do have caregivers who have cared for patients in the past with Parkinson's and who have that experience. Not all angels are going to have experience with that. We do provide small group training too for caregivers who need it or want to learn more about that. If they have a new client that has Parkinson's and they really hit it off and they want to learn more, maybe they have more of a basic understanding, but they want to dive in more. So not all angels have the same training. So that's why we're creating that care plan and matching you with someone with the right skill set.
I do have a question. Somebody asked about Lewy body dementia, but then I do also want to go back to Stacy. So I'll have you answer that question about, you talked about matching people, like how, like if they get along with their caregiver, or if they say they want somebody else. I want to get to that, but is there the same question with Lewy body dementia instead of Parkinson's, or really any dementia?
Yeah. Right. Yep. So same with dementia. We have caregivers who have a lot of experience providing care for dementia patients, and others who are not. So that's why we're going to match you with a specific caregiver that has that experience level. They have those tools, they have the training, but also providing extra training for caregivers who need it or want it. So you always have a choice of the caregiver that we send out. If they're not the right fit, just the chemistry is wrong or the skill set is wrong. They may seem like the perfect fit, but you've met them a few times and you're just realizing it's not quite right for whatever reason. That is what we're here for. That's what the agency's job is for you to call us and communicate what's working or not working, so we can ultimately find the best fit for you and try somebody else. So you are never stuck with a caregiver that's just not working, whatever the reason is.
Agreed. Same for us too. So specifically with Inhabit, we just do program books for everything. So these are educational books that are left in the home with the patient, with the caregiver, and they're titled all sorts of things. I currently have fall prevention and a caregiver handbook with me, but we have one for memory care as well. So that falls under all of that. And then all of our clinicians do obviously continued education as well. So they have classes that they can take for free through the Inhabit site, that they can continue education if they are seeing a more specific population of patients that they want to know more about. So we have that option. But same thing as Stacy was saying, if you have a clinician who comes out and you are just not vibing with them, because unfortunately we don't necessarily match like they do based on your based on your needs and the skills of the clinician, because they're all clinicians, and they all have the same license. And so we don't do a match like that. But that being said, if a clinician goes to your home and you guys are just not vibing, that happens, personality conflicts, you can call your office of the home health agency and just be like, hey, George did a great job, but I would prefer if it's not him who comes out the next visit. And totally not a problem. Like, we get it. Not everybody likes everybody, and it's totally fine. No feelings are hurt. You don't have to feel bad about it. And we do our best to keep George from coming to your house ever again. So that's totally optional, and not something to, not bring up if you feel uncomfortable about it.
And then I have a question about medication. Someone wrote into me. So you guys kind of touched on, but I could get a little bit more elaboration. Like, Stacy, caregivers will not dispense, but they can do reminders. Amy, the nurses can do this, but then also, for example, like, what if, because that can't be forever. Like, every 2 weeks, a nurse is not going to come to your house. Would a social worker, for example, be able to contact the local pharmacy on the patient's behalf and set up maybe getting like the packets and get it delivered? Like, who can handle what? Or like, Stacy, could the caregiver go to the pharmacy and pick up the pill? Like, how can that's a big question, because obviously with Parkinson's, the medication is a big deal. Could you just tell me a little bit about who can help with what so that this can get addressed?
Yeah, if it's a continued thing, and we've been going out for several months and there hasn't been any kind of improvement on the patient being able to manage their own meds without our nurse filling their pill boxes, we can definitely get the social worker involved, and have them help create a plan with the pharmacy and with the doctor as well. That way we are just not using Medicare benefits for no reason if the patient's not benefiting from them. Also too, if there isn't a nurse in the home, it's just like therapy or occupational therapy or speech, even they can be like, hey, are your meds right? And they can do a med check as well. They won't be filling the med boxes like the nurses do, but they can check and make sure everything's great. And that in our computer system and the way that they document everything, it'll still tell them if they see a new med on the counter that's not on the patient's med list, they can add it into it and it'll pop up and say, hey, it's conflicting with another medication or XYZ, something like that. So it doesn't have to just be a nurse. While they are the ones doing the main like filling of the pill boxes and the education of it, our other disciplines can step in as well. But we do always include the doctor on any changes from any of our disciplines. If anything's going on, if we are no longer bringing a nurse, we're going to tell your doctor about it as well, just so that they're aware, and we're going to keep them updated if there hasn't been a progress with the patient learning how to manage their own pill box.
Yeah, so if we are seeing a client who needs medication reminders, maybe they're newly home from the hospital or rehab, they have had some changes, it is a little confusing, but they do have home health. Home health, we'll get that pill box set up, that nurse is going out, we'll get it dosed and set up. But as far as then what do I do for kind of the ongoing management of it, if it is still too difficult? typically, if there is a family member involved, you know, we often will have a daughter or somebody who just comes every week or once a month or every 2 weeks and they fill it, but we can physically touch it and give it at that point as long as it's dosed. If there isn't anybody like that can do the actual filling of the pill boxes, we will then brainstorm and help find solutions, whether that is recommending like the pre-packaged dosed little packs that your pharmacy can do. There are like electronic dispensers. We have a lot of clients that use those where they just spit them out and there's alarms that go off. There's even ones that like tie to an app on your phone where a family member out of state can help monitor and they get reminders. So we will help troubleshoot and recommend different options based on that specific situation. And what other piece of the puzzle needs to be in the home if it's not strictly just reminders.
This question is for both of you, but I'm going to start with Stacy. So now you have a caregiver who's maybe been in the home a little while, and that caregiver's starting to see some changes that is concerning the caregiver. What do they do to maybe reach out to the family? What happens in that situation to kind of say, hey, maybe home isn't as safe as it used to be? And like Amy, for you to kind of say, hey, you know, we're trying to do these skills and this isn't maybe where we wanted to go. So kind of just, I wanted to start with Stacy, but like, how do you deal with that? How do you approach that?
Yeah, and sometimes we are in the home with that being a major reason, kind of that well-being observation and reporting piece of that component. If you don't have any local family, and this can help serve as another set of eyes and that fresh pair of eyes who's coming in and seeing someone on a daily basis or weekly basis that can notice those big changes and report it. So caregivers will call the office and report anything concerning, whether it's we're having increased falls or something in the home needs to be modified, even to the heat. I think the heater is broken and it's too hot in here, or I think there might be bed bugs. What do I do about that? Or I notice she has this different cut or bleeding on her arm that wasn't here the last time I was here, or increased confusion. So any changes, they're going to report immediately to the office, which every client then has a list of responsible parties or like an emergency contact where we will notify who that client has chosen for us to call in order to report those types of things. Whether then we need to make recommendations, we will help the family members call an AC guy if we need to, right? Make a recommendation locally on if there's a bug service, or do we need to contact the home health? Because we have that in their chart too, if they are currently receiving home health services, and contact them for some sort of issue. So we are kind of that coordinator and go between to help try to solve those problems.
And for us, it's kind of hard. It's a lot of pieces. So if it's medical, if we notice that you are falling more, if memory issues are becoming more of a problem, if you're living alone, especially in nighttime falls when you get up to go to the bathroom or something like that, or if we notice that your strength has significantly decreased, you went from just needing someone to kind of hold your hand when you stood up, now you need someone to really just hoist you up. So if anything huge like that is happening, we're calling your doctor immediately to be like, hey, there's been a significant change. Maybe the patient needs to come into the office. But if it's a consistent continued change, we're going to look at the next step. So usually for us, that means if it's not anything emergent, we are not sending you to an emergency room or to an ER. We are going to look at like an inpatient rehab, because if you were doing pretty okay and now you're not doing okay, usually you just need a more oversight of care. So an inpatient rehab would have doctors around the clock for you, as well as aggressive therapy to get your strength back up. So that's usually the first option we look at. Here in Georgetown, we partner with Encompass Rehab. They're a rehab in the Round Rock area. big partnership with them. So those are the people that we generally will reach out to. But if a patient has been to another rehab in the past and really likes them, we'll reach out to them as well. And usually patients can get admitted to a rehab from home. So it's not like you have to see your doctor first or anything like that, if that's the safest trajectory for you. If it's not, if it is something emergent, we have clinicians who are in the home all the time who make the 911 calls and have an ambulance come out to see you, to take you to the emergency room or to do whatever it is, whether it's super low blood pressure or you're unconscious when they show up or whatever it is. Our clinicians are very great at handling what the next steps are if something is going wrong in your home. If it's things like, you know, your AC or your heater is out, or there's a large clutter situation that makes it unsafe for the patient to move around, and there's not family that we can discuss things with, or if the patient doesn't have any desire to take the next steps to get those things fixed, we will call APS to get APS involved just for the safety of the patient. And we work with them a lot too, unfortunately, when we have to. So we always are just making the best decision for the patient to be safe.
We did have a question. Is hospice a part of home health?
Separate, but yes. So with our specific company, Inhabit is home health and hospice. So we are two separate branches under the same umbrella. There are a lot of hospice agencies that are completely on their own. They don't connect to a home health at all. So with us specifically, it's just something specific that we do, because it's a nice branch to when you need it for a patient that has been on services for a while and they're not progressing and things are just not turning up, then we do talk to our hospice, and it's a nice bridge program that we can create for an easy transition of care for the patient. But not every home health agency does that. There are several that do, but not everybody. So it'll just depend on where you are and what agency you're looking at.
We have a few minutes left. So I was curious, and I hate to put you on the spot with this one because I realize this might seem like an interview question, but can you give me a feel-good story in your fields? Because I imagine you have a few. I just feel like I'm putting you on the spot where you're like, I have them, but you're asking me to recall them right now. And I don't hence the interview type question, but I'm sure you guys have them. And I was wondering if you could share one.
Stacey, that's you. I gotta think.
I'd say just one recently because I just saw her today. We first provided care for the husband. He was on hospice services, actively passing away. They needed extra support in the home. So they had 24-hour care from us, husband and wife. She was extremely overwhelmed and needed us just bedside for kind of all of that support and comfort and be with him at night and all of that. Well, now 6 months later, he did pass away. She's been living on her own. But now she had a neck injury. So she's having to wear a neck brace. She's living on her own. So I met with her then again today to sign her up for services for herself. And she was just extremely emotional and grateful just thinking about the angels that she had. She even mentioned, of course, them by name and are they still working with you? And I said, yes, actually, they are. So we were able to then send them now out to her and provide care for her for this whole other different situation. And she was just extremely grateful to have someone there with her during a really difficult time, but who was knowledgeable about what was going to happen, but who could be calm and comforting, but she could rely on them kind of knowing what was about to happen.
I love that because also she already knew them. So it was almost like she had an old friend in the house.
Mm-hmm.
Yes.
Yeah, I like that. Mine's a little different. It's more just generalized. I unfortunately don't get to go into the patient's homes and work with them on what I do. I just chat with them on the phone, pre-visits and post-visits. So for me, it's really just being able to be the ear that a patient or a caregiver needs. There are lots of questions, obviously, when people begin home health, and there's a lot of stressful, I don't know what we're going to do if this keeps happening type conversations. So I really appreciate being able to be the ear for someone and just letting them unload for a little bit, because as a caregiver, it's obviously very hard dealing with all the stress that it comes with it. And then when you're a patient, if you don't have any extra support, you just need somebody to listen to you. So I do love that aspect of it. But then I get to call them after they've had a couple of visits to make sure things are going well, that they're vibing with their clinicians. That's a big thing. And so when a patient is like, same thing, they name our clinicians by name and they'll say, Chase, man, he's a funny dude. And he is just making me so happy when he comes into our home. And he's teaching me all these cool exercises. And I did these exercises on my own. So just hearing them be excited about the care that they're getting, really connecting with their clinicians is very cool. And I get to pass that along to the clinicians. I get to say, hey, I talked to Mr. George and he's super into you. Like, he's so happy that you get to come by. Do you have him on your visits next week? And he'll be like, yeah. So it's exciting for the clinicians to be able to hear like that they're vibing with the patients, like the way they thought they were. And it's just cool to hear the patients like know that they're getting something out of the services that we're providing. So a little more generalized, but those are my favorite phone calls.
I love that though. He's like, yeah, he's cool. I love that. Well, thank you so much. This has just been incredible. I really feel like the both of you just did such a wonderful job explaining what home health and home care is, what it isn't, who pays for what, why it's important. I'm so grateful you could join us today. I think this was just wonderful. As always at PMD Alliance, we have a tradition, our wave of gratitude. Thank you everyone for joining us today. And thank you so much, Amy and Stacy. You gave us so much valuable information. I can't thank you enough.
It was a
Have
pleasure.
a good afternoon, everyone.